Good morning. This morning I want to talk really briefly on Chapter 6, which deals with the content of the patient record, both as an inpatient, outpatient, and in physician office records. Healthcare providers are responsible for maintaining a record for each patient who receives healthcare services. Now, this should only be done if the facility is accredited, which means that the provider must comply with standards that impact patient record keeping. Therefore, facilities have to be licensed, they have to be accredited to even be operating as a medical facility. In doing that, in keeping up as being a licensure and an accredited facility, they have to make sure that they maintain compliance with whatever the standards are as it relates to a patient's record. Joint Commission standards require that the patient record contain patient-specific information appropriate to the care, treatment, and services provided. Patient records contain both administrative and clinical data. This past week or last week, or this week rather, you're working on an assignment that has to do with clinical and administrative data. The book also goes into detail as to how you classify those pieces of information. All of those pieces of information, whether they're clinical, administrative, or financial data, or socioeconomical data, all of it has to be protected according to Joint Commission and according to HIPAA regulations, because all of them contain pieces of a patient's medical information. Anytime you document into a patient medical record, it needs to be accurate. It needs to be promptly completed or promptly recorded. That pretty much means as soon as you're done, or as soon as the physician is done with diagnosing a patient, or as soon as he's finished with visiting with a patient, like nursing, as soon as they take the vital signs, those things have to be promptly recorded. Patient records have to be properly filed. Patients' records have to be properly retained, and they need to be accessible. Now, one thing that the hospital uses, they have a system, a way of identifying and maintaining their records. We call that the Medical Records Department, or the HIM Department, the Health Information Management Department. Those particular departments inside of a hospital, they manage how patient records are maintained, and if the floors need copies of records, they have a system in which all of that is taken care of. Now, in a doctor's office, it's pretty much maintained usually by the front office and the nursing staff. They too have systems in which they maintain patient records, but it may vary depending on the type of system that they actually use. Now, let's talk about some general documentation issues or some general guidelines as it pertains to patient records. So the first slide I have up here talks about patient identification, facility identification, addressograph, dating and timing patient record entries. Now, for patient identification, the patient record is a valuable tool that documents care and treatments of the patient. I'm going to say that one more time. The patient record is a valuable tool that documents care and treatment of the patient. So therefore, it's essential. It is very, very essential that every report that is contained in a patient record has patient identification on it. Every single report. So if you got a report on a patient and they have 50 sheets in there, varying things, x-ray labs, it doesn't matter. Every one of those sheets of paper should have some sort of patient identification on there. So when we talk about patient identification, the things that we're talking about, as I have listed the slide, will be like the patient's name, first and last name, middle initial if they have it, the patient's medical record number, and the patient's date of birth. Again, every report in the patient record, manually and every report in the patient record electronically must include patient's name, medical record number, date of birth, and any other identifying information the facility wishes to use. Now, when you have an instance where you have paper that is two-sided, meaning there's information on the front and the back, even in that instance, patient information should be on both sides of that sheet of paper. Okay. Facility identification. In facility identification, the main things that you want to have on there is the actual name of the facility, the mailing address of the facility, and the telephone number. Most places may include, some places may include a fax number, but you want to make sure you have the main number on that particular document as far as facility identification. Now, how is most of this done? By way of an addressograph. Addressograph is basically a plastic card or a label that contains patient identification or facility identification. It is usually used by way of an addressograph machine, and basically it imprints the information on the report for you. The plastic card looks just like an actual credit card, but except the difference is the patient information is already there. Dating and timing record entries. Whenever you date and time patient record entries, one or two ways. It may be done by a 2-digit month, two-digit date, and a 4-digit year, or in some cases is formatted using military time. For a record to be admissible in a court of law, according to the Uniform Rules of Evidence, all patient record entries must be dated. In order to use a record, or in order for that record to be admissible in a court of law, the entries must be dated and timed. So, let me go back to what I said previously, correct what I said. In the dating and timing records, it is the month, day, and year that's 2-digit month, 2-digit day, and 4-digit year. And in the time, when you record the time, you use military time. So I want to clear that up. The month, day, and year, the format is 2-digit month, 2-digit day, 4-digit year. And when you're recording the time in a patient record, it must be using military time. For example, a 4 a.m. or 5 a.m. blood sugar is 0400, 0500, whereas a 4 p.m. and a 5 p.m. sugar would be 1600, 1700. Now we're going to talk a little bit, really briefly, about content of a patient record, and we're going to start first with a hospital inpatient record. We're going to talk about hospital inpatient record, and we're going to talk about some different pieces of what we call administrative data. The very first piece that we're going to talk about is the face sheet. Now, I will make mention of this. It is going to be very important that as you read Chapter 6, you make notations or make you some notes of how the different patient records are assembled in the chart. I say that because your project is going to consist of you putting together a patient's medical record. And you're going to be responsible for making sure that you take the medical record entries that you are given and place them in the correct order inside of the patient's chart. And you will be breaking it down as far as administrative and clinical data. So you really need to make sure that you read through Chapter 6 to learn how to put that patient's chart, or how to put a patient's chart together correctly assembled. So the very first document in our administrative data for a patient record is the face sheet. Now, let me back up and tell you when we talk about administrative data, what things are we referring to? We're referring things to demographic information, socioeconomic information, and financial information. This is the information that is gathered upon the mission of the patient to the facility. And a lot of this information is documented on the face sheet, or what we call an admission or discharge record. So the face sheet is filed first. And the reason it's filed first is because you're going to frequency it often, meaning that you're going to be looking back at that particular sheet often. It will contain like the admitting diagnosis, and that's like the condition or the disease in which the patient came to the facility seeking treatment. Now, whereas Joint Commission does not specifically require a face sheet, it does require that all medical records contain identification data. Joint Commission also has a rule that completion of all medical records on patients must be done within 30 days following the patient's discharge. Now, keep in mind, we're talking about a hospital record. We hadn't got to an office, a doctor's office record yet. Okay, now, following the face sheet, you have what you call a document that is for advanced directives. So these are legal documents that pretty much tells individuals how a patient wants to be treated in the event they become ill, and in the event they become ill to a point where they cannot speak for themselves. So the Patient Self-Determination Act 1990, it required that all healthcare facilities notify patients 18 and over that they have a right to an advance directive. These examples include healthcare proxy, living will, medical power of attorney. Facilities must inform patients in writing of state laws regarding advance directives and facility policies regarding the implementation of an advance directive. So upon admission, a ADN, Advance Directive Notice Form, is signed by the patient so that the patient can document, or that so that the patient can sign that they have been notified of their right to have an advance directive. A lot of people don't have one, but that option needs to be presented to patients in the event they want to have one as part of their medical record. Again, the advance directive is a legal binding document. A legal binding document. Now, some types of advance directives are things like a do not resuscitate. And I have a picture of that in one of the slides, but you have a DNR, a do not resuscitate. Basically, it instructs medical professionals not to perform CPR in an attempt to keep the particular patient alive. That goes for doctors, nurses, any kind of emergency medical personnel. When a patient has signed a do not resuscitate, in other words, if they stop breathing, they do not want you to perform CPR on them. Now, unless a patient has that in their record, in the event the patient stops breathing, the medical professionals, doctors, nurses, EMTs, they should do everything possible to keep that person alive and get that person breathing back again. Another type of advanced directive is what we call a living will. So this is a legal document in which patients state the kind of care they do or do not want under certain circumstances. It also talks about, a lot of times in a living will, it usually outlines who gets what, who is left what, who gets the house, who gets the car, who gets this, who gets that. Sometimes people may outline how they want their funeral, or they may outline they want to be cremated, or they may outline they want to be buried at a certain place. All those things are usually typed up into a living will. A healthcare proxy or a doable power of attorney. This is a legal document in which patients name somebody close to them that will be the one to ultimately make their medical decision. So this would be the person, say for instance, you got on life support. This person has already been assigned by that patient as the power of attorney to be the one that speaks on the behalf of, yes, keep them on the breathing machine, no, take them off the ventilator. They're the person that's already designated to be able to do that. Informed consent. Informed consent is a procedure in which patients are advised of any treatment options, risks, and benefits of any type of test and procedure that they're going to have done. So for an example, say for instance you got to have surgery done and you have an irregular heartbeat. The physician is responsible to having a conversation with you to let you know that because you have this irregular heartbeat and you got to have this type of surgery or that type of surgery, there's a possibility that X, Y, and Z could happen. 25%, 50%, 75%. Or there's a possibility you could have issues with the anesthesia. Whatever the risk associated with a test or a procedure you're going to have, whatever benefits you're going to have with doing a test or a procedure, or even if you have some other options, those have to be given to you by the physician, and that's called informed consent. Now, the next slide is just an example of what a DNR looks like, and as you can see, it has all of the pertinent information. Of course, the very first sentence says, I, and you put the patient's name in that blank, DNR, okay, do not authorize resuscitation in the event of cardiac and respiratory arrest. And basically that means if I stop breathing, do not resuscitate me. Now, we're continuing on with the hospital inpatient record, administrative data. The next thing we want to talk about is consent to admission. So upon admission, the patient may be asked to sign a consent to admission or a condition of admission. And this is where the patient basically gives the facility permission to treat his or her condition at the time of admission. Consent to release information. This has to be signed by patients. They have to give signed authorization for their medical records to be released, whether it's for reimbursement or other purposes. They also have the options of placing names in their medical record of individuals who have access, who can be given access to their medical records, as well as those who should not be given access to their records. Now, special consent forms are usually those forms that are signed for special things such as surgeries, any kind of diagnostic and therapeutic procedure that a patient has to undergo. It is required that written consent be obtained from the patient or the person that may be representing the patient, which indicates that the patient acknowledges informed consent. It means that they have a clear understanding of the nature of the treatment, the risk, the complications, and any alternative forms of treatment available. They're also signing, when they give special consent for surgeries and different things, that they are well aware of consequences of having the treatment or the procedure done. Continue on. Next, we have the patient property form. Basically, this is the form that when the patient's being admitted to the hospital, any belongings that came with that patient, they pretty much have a form where they record those items so that when they're ready for discharge, the hospital can make sure that those same items goes home with them on the day of discharge. It is important for the staff member to complete this form correctly, as some patients claim that they arrived at the hospital with items they do not actually possess. So whoever fills out the form with the patient must be sure, must fill it out accurately, because if not, it's a possibility patients could say, oh, this is mine, that is mine, and that's not necessarily theirs. So that particular document is actually very, very important. Then you have what you call a certificate of birth. You normally see this mostly with your newborn patients. It is basically birth information about the newborn patient and their parents. It identifies medical information that includes the pregnancy and birth of the actual newborn. Birth certificates have certain contented information such as the infant's and the parents' demographic information, parents' occupation, education, race, any medical risk factors or complications or any abnormal conditions of the newborn that may have occurred. Now, the next form is certificate of death. That's pretty much information regarding the decease of a patient. On that form, it usually lists the cause of death and the disposition of the body at the time. So it may have things like the name of the deceased date, place of birth, the cause of death, the deceased place of burial, names and birthplace of both the parents, name of the doctor, the method and the place of the decomposition of the body, signature of the funeral director, and the certifying physician. These are all classified on a certificate of death. And this is usually the document that's, if something has to go to court or if someone needs to get paid out insurance, death benefits, these are things that's usually required. Or say for instance, if you got to go to the insurance company and get the insurance money to pay for this, that, and etc., and then get what's left for stuff, one of the things that they're going to ask you for is a certificate of death. Now let's talk a little bit about clinical data inside of a hospital inpatient record. And we're going to start with let's start with what clinical data is. This is the data that includes all healthcare information obtained about a patient's care and treatment. Now, it may be documented, it's documented on numerous forms in the patient records. Okay, so the first document we want to talk about is the emergency record. And that's pretty much any documentation, an evaluation that has the evaluation treatment of that particular patient while they were in the emergency room. Now, the discharge summary can come one of two ways. If you go to the emergency room, a discharge summary could be generated there. Definitely after the patient is discharged from the hospital, there is a discharge summary given on that particular patient. Let's say, for example, patients had to be transported by an ambulance. There is a such thing as an ambulance report, okay? And they have all of their particulars that they put on that report that goes in that patient's chart. Now, to give you another look, I want to make one other little note about the discharge summary. When a patient is transferred to a different level of care within the same hospital, the discharge summary at that point is called a transfer summary. I'm going to say that again. When a patient is transferred to a different level of care within the same hospital, the discharge summary is then called a transfer summary. And this is then notated or documented in the progress notes if the same practitioner continues to provide care. Now let's talk a little bit about the history and the physical examination form. Joint Commission standard states that history and physical exams must be performed and documented in the patient record within 24 hours after admission. This does include weekends and holidays. Now, if a history and physical exam was completed within 30 days prior to the patient's admission, reviewed and updated, it can be placed on the record within 24 hours after admission. That means that the patient either have undergone no changes to the original examination or the changes must be documented upon admission. But basically, the history and physical examination, this is basically where you go back into the patient's history, get known facts about the patients and the patient's family. The physical examination is where you actually do the physical look at the patient and with your pertinent findings. Next report is what we call a consultation report. So basically, this is where patients have sat down with the physician and they've had a consult. They've asked questions, got opinions from the physician on the findings based on the physical examination. So like say for instance, the doctor say he saw something, patient may say, oh, well, can we go and sit down and talk about it? And, you give me your opinion. What do you think I should do? What do you think is the best option? Which route do you think I need to go? That's called a consultation. And basically it's where, again, a physician's opinion or advice is given, or it could be one of those things where the patient was sent from one physician to another to get a second opinion. Next, we have physician orders. Physician orders, sometimes called doctor's orders, they pretty much represent any diagnostic and therapeutic procedure the doctor wants to have done on the patient. Progress notes are those statements that are solely related to the patient's illness. They're usually recorded in a patient's record all the time. And when I say recorded in a patient's record, I am talking about both manually and electronically. Progress notes contain statements related to the patient's illness, related to responses to treatments, and the patient's status at discharge. Progress notes are usually organized in the record according to discipline. And when I say discipline, I'm talking about physical therapy, surgery, labs, things of those natures. Anesthesia record. Anesthesia record is usually that record that is given to patients that require anesthetic agents. So pretty much these are the agents that put you to sleep. Okay? So anytime a patient undergoes surgery and has to have anesthesia, this record must be filled out. This record should contain pre-anesthesia, post-anesthesia, what happened to the patient prior, during, after. Patient having surgery, they're going to have an operative report. And in the operative report, there are several things that's going to be included in that report. Those things include gross findings, any organs that were examined, and the techniques that the physician used to perform the actual surgical procedure. Major and minor procedures. So just to give you an example, a major procedure, carpal tunnel repair, cervical discectomy, lumbar fusion. These type of surgeries may require hospital stay, and it usually take a little longer time to perform these surgeries, and is a little bit more risky than a minor surgery. Now, a minor surgery or a minor procedure may be things like trigger point injections, administration of an epidural, or insertion of a pain pump. And a lot of times, minor procedures could possibly be done in one-day surgery where the patient doesn't have to stay extra overnight. They can go home that same day, unless the physician feel like the patient needs to stay for an observation overnight. Now, anytime, most of the time when surgical procedures are done, major or minor, patients usually end up with a pathology report, and this is used if the physician had to remove tissues that have to be examined, and then based on that examination, the physician is further able to diagnose and treat the patient. Post-anesthesia care unit, what I mentioned before, that's usually completed when the patient goes to the recovery room. It's during that time, they're looking at vitals, they're checking the patient physically out to see, and then they're recording how long it took them to wake up and things of that nature. Now you have what you call, then you have your ancillary reports. So your ancillary reports can be things, for example, like laboratory. And that may be if the patient had any kind of blood chemistry examinations done, maybe they had some drug tests done, some blood gases. It may include things like the patient's blood types, if the patient had any kind of genetic testing. Basically, clinical lab reports, they have on there name, date, time of lab tests, the results, the time the specimen was logged into the lab, the time the results were determined, any reference section like normal ranges and lab values, and of course the initials of the lab technician. Another auxiliary report is radiology. Radiology reports give descriptions of images that were x-rays, the techniques that were used, the narrative report of the findings, the diagnosis, and the authentication by the radiologist. So that can include basic x-rays, nuclear medicine, MRIs, PET scans, CAT scans, ultrasounds. All of those are examples of radiology information that can go into a report. You also have what you call EKGs or ECGs. These are pretty much printouts of graphic tracing of electrical changes in the heart muscle as it pertains to the patient. EEGs, same thing, except these are graphic printouts of electrical activity of the brain. Then you have the EMGs. These are the graphical printouts of measurements of skeletal muscle activity. And then, of course, you have your transfusion records. And so your transfusion records are those records that include any blood that the patient had to receive, cross-matching of that blood type and RH factors, donor's identification number, and the notation of any type of transfusion reactions that may have occurred. Nursing documentation is another part of clinical data, and this plays a crucial role in patient care because the majority of care that is given to inpatients is given by nursing staff, and we're talking about RNs, LPNs, and CNAs. So, upon admission to the hospital, a nursing assessment is documented, and that helps to obtain the patient's history and evaluate vital signs. So normally when you go in, that's like once you've admitted, it's not long before somebody comes in, and they ask a few questions, they take a few vitals, and you find out who your nursing staff is, do you need anything, and it just kind of picks up from there. Information in nursing documentation is used to create what you call a nursing care plan, and this basically records diagnosis and interventions with the patient, vital signs, administration of any kind of medicines, observations, and progress during the patient's entire time as an inpatient patient. Plus, it also helps with a discharge plan for the patient. Now, there are other parts of clinical data in a hospital inpatient that includes OB records and neonatal records, and of course, these are all of the things that are attributed to pregnant moms and their babies, their male and their female patients, the male and female newborn patients. That record contains newborn identification, any physical examination of the newborn. It too contains progress reports as well. So when the mother goes in, some of her records include a prenatal record, a labor record, a postpartum record, newborn footprints. All of those are housed into what we call an OB record, and it has those particular reports. Birth history is in there. That documents the summary of the pregnancy, the labor and delivery, and the newborn's condition at birth. Newborn identification is up in there. That, I already mentioned the footprints. Newborn physical examination that happens right after the birth. It includes the time and date of birth, vital signs, birth weight, length, head and chest measurements, general appearance, and physical findings as well. Newborn progress notes. This is documented by nurses in the nursery. It includes vital signs, skin color, intake and output, weight, medications, and treatments and observations of the newborn baby. Next, we have autopsy reports. That's examinations of a body after the body has been deceased. So it includes macroscopic and microscopic examination of vital organs and tissue specimens, and they use this to help determine the cause of death and the character or extent of changes produced by the disease. Now, prior to obtaining autopsy, consent must be obtained from the legal next of kin of the deceased, and assigned consent form becomes a part of the patient record unless the autopsy is performed based on a coroner's case or based on state law. So if it's like a homicide or something like that, yes. But a lot of times, if it's like a natural death or something that's kind of expected or whatever, if an autopsy needs to be performed, that will need to be requested by the next of kin to the patient. Now, let's talk a little bit about a hospital outpatient record. Outpatient care is defined as medical or surgical care that does not include an overnight hospital stay. Does not include a hospital overnight stay. Hospital outpatient services usually include diagnostic, therapeutic, and rehabilitation services. So what I did is to prevent from having to go back through the same forms all over again, I just kind of gave you a listing if a patient was going for outpatient surgery and they was just going to be like a one-day surgery, did not involve a hospital stay. The main forms that are listed in that patient record are what I have listed here. Patient registration form, any ancillary reports. Remember the labs, the x-rays, you have the progress notes, you got physician orders, you got operative reports, you got pathology reports, and nursing documentation. Same thing with a physician office record. If you notice, that record is a little bit more shorter because basically that's pretty much everything that happens in that doctor's office. So there's things going on, but it's not that much. So that particular record would include things like a patient registration form, of course, problem list, the reasons or the problems that are generated as to why the patient is visiting the physician's office. Medication record, any kind of medicine that may be given to the patient while they're in the physician's office, progress reports, ancillary reports, and then in a doctor's office, they have what you call encounter forms, which is like super bills or fee slips. They have those. Those help with generating the medical claims. Now, all forms have to be approved by what you call a forms committee or patient record committee. Basically, their role is to help facilitate the use of the patient record. They help to streamline approval processes for documentation. Their job is to make sure documentation is in compliance with federal and state standards, and they have to make sure that the quality of documentation is there as well. Their job is to help keep the form simple but captivate all of the necessary information that is required. So this concludes the audio lecture for Chapter 6. Again, be sure that you go through Chapter 6, read all of the, read back through the chapters, and make sure you pay special close attention to chart assembly so that you can be prepared for your final project that will be given, that you will be doing week 4 of the term. Thank you.